So let's break down exactly how this unfolds. First, you have normal, healthy neuroendocrine cells just quietly doing their job, sending out hormonal signals. Then step 2 happens. Now, we don't always know why it starts, but a genetic mutation occurs. Sometimes this is linked to a specific genetic condition called MEN1, or multiple endocrine neoplasia type 1. This gene mutation basically gives patients a higher chance of developing these tumors, especially in the lungs and the digestive tract. And that brings us to step 3. This mutation triggers unchecked cellular multiplication. The cell mutates and it multiplies, gradually forming a tumor. But here is the absolute key thing to remember. These tumors are typically very slow growing. That means they can just hide out in the body for a really, really long time before anyone even notices they're there. Because they grow at such a snail's pace, you might be wondering, how do we actually find them? Well, this leads us to something we can call the Appendix Surprise. Picture this. A younger patient rushes into the emergency room with severe abdominal pain. I mean, it looks, feels, and acts exactly like classic appendicitis. So the surgeons go in, they do a completely routine appendectomy, and it's only after they remove the appendix and test the tissue in the lab that they discover a hidden neuroendocrine tumor. It is a total surprise diagnosis, found right in the middle of an otherwise totally routine procedure. Now, once these tumors actually start growing, they attack the body in 2 completely distinct ways. First up, we have non-functional tumors. Remember that appendix we literally just talked about? That is a prime example. These tumors don't produce extra hormones, they cause problems purely through physical force, just their physical size and location. Like, if one grows in the small bowel, it can create a physical obstruction, leading to serious abdominal pain, constipation, nausea, the whole 9 yards. But on the flip side, we have functional tumors. And wow, these are a completely different beast. They act like rogue factories, just dumping excess hormones directly into the patient's bloodstream. So you aren't just dealing with a physical mass anymore. You're dealing with outright chemical warfare inside the body, and that causes severe systemic symptoms. To really wrap our heads around these functional rogue factories, we have to look at where they live. The tumor's primary location completely dictates the chemical weapon they use, which then dictates the crazy symptoms a patient feels. Let's say the primary tumor is in the small bowel or the lungs. It tends to overproduce serotonin. That leads to what we call carcinoid features, severe skin flushing, chronic diarrhea, and even wheezing in the lungs. On the other hand, if the tumor sets up shop in the pancreas, it might overproduce insulin. What happens then? A dangerous drop in blood sugar, leaving the person feeling super nervous and irritable. Or it could do the exact opposite and overproduce glucagon, causing high blood sugar and bizarre skin rashes. Because of all this chaos, it can take 5 to 7 years for a patient to finally get an accurate diagnosis of a neuroendocrine tumor. 5 to 7 years. Just imagine that. Years of suffering, of uncertainty, of bouncing from doctor to doctor. These tumors are pretty rare. They affect about 4 in 100,000 adults, and because they grow so slowly, they are incredibly tough to pin down. But the real underlying reason for this massive diagnostic delay, it all comes down to how well this disease disguises itself. The symptoms are just incredibly diverse and overlapping. Imagine a patient visits their primary care doc. 1 month, they're complaining of severe diarrhea and stomach ulcers. A few months roll by, and suddenly they're experiencing intense skin flushing and wheezing. You know what happens? The wheezing gets totally misdiagnosed as asthma or pneumonia. The stomach issues, written off as irritable bowel syndrome. Because these symptoms are driven by fluctuating hormones just bouncing all over the body, the poor patient gets sent to a dozen different specialists. Each one is looking at individual symptoms, completely missing the underlying systemic rogue factory causing the whole shebang. It becomes an absolute medical mystery for both the patient and their local doctors. So right now, you might be thinking, hey, can't we just run a simple blood test and be done with it? Well, we actually do have a specific protein marker we look for called Chromogranin A. It's found right inside the neuroendocrine cells. But there is a massive catch. You have to beware the false positive. This blood marker is so incredibly sensitive that if a patient eats everyday foods like tomatoes, avocados, kiwis, or even nuts right before the test, it can artificially spike their Chromogranin A levels. No way, right? Even taking common steroids or just having uncontrolled high blood pressure can trigger a false positive. Relying purely on this one test can cause immense, unnecessary anxiety. And that's exactly why specialists do not recommend just ordering it routinely for everyone. So how do we cut through all the confusion? Well, when a specialist suspects a neuroendocrine tumor, they bring out the heavy machinery. Right now, the absolute gold standard is the Ga-68 DOTATATE PET scan. Guys, this technology is incredible. They inject a highly specialized tracer that specifically hunts down and binds to the tumor cells, literally lighting them up on the scan. It's like the doctor is painting the tumor's bright neon inside the body. This is usually paired with a super high-quality, contrast-enhanced MRI to perfectly map out the abdomen. And finally, to seal the deal, you need an expert surgical biopsy. A specialized pathologist has to look at that exact tissue under a microscope to confirm the precise type of cancer cells we're dealing with. All right, once we finally have an accurate map and a confirmed diagnosis, how do we fight back? This brings us to a truly revolutionary treatment called PRRT. That stands for Peptide Receptor Radionuclide Therapy. Think of this as a highly advanced radioactive smart bomb. You see, unlike traditional chemotherapy that just blindly attacks fast-growing cells all over the body, PRRT is completely targeted. Neuroendocrine tumor cells have these specific little targets on their surface called somatostatin receptors. PRRT medications are explicitly designed to seek out and bind only to those specific receptors. This means they deliver localized radiation directly into the cancer cells while leaving the surrounding healthy tissue alone. It's brilliant. Let's actually break down how the most prominent PRRT drug, Lutathera, also known as lutetium-177, pulls this off. The process is a brilliantly sequential operation. First off, it's injected intravenously into the patient. Step 2, this therapeutic radionuclide circulates through the bloodstream, totally ignoring healthy tissue until it finds and tightly latches onto the somatostatin receptors on the tumor cells. Step 3, and this is the real game changer, the medication is actually internalized. It gets pulled right inside the tumor cell. And finally, once it's locked inside the enemy gates, it releases localized radiation over time, effectively dismantling and destroying the tumor from the inside out. Now, the crucial thing to understand here is that this targeted strike isn't just one massive, overwhelming blow. It is an 8-month treatment journey. It consists of just 4 cycles spaced roughly 2 months apart. So a patient rolls into the nuclear medicine clinic in the morning, gets their IV infusion, receives some protective fluids to keep their kidneys safe, and they're done in about 5 hours. It's an entirely outpatient procedure. Just 4 days in a clinic spread over 8 months to treat a metastatic systemic cancer. And the side effects? Generally very mild, usually just a little bit of nausea from those protective IV fluids. So what kind of results do we actually see after this remarkable 8-month process? Well, we see physical tumor shrinkage in about 20 to 30% of patients. The radiation does its job and the masses literally get smaller. But actually, the even bigger success story isn't just about the shrinkage, it's about stabilization. For the massive majority of patients who go through this therapy, the radiation completely stops the tumor from growing. It just locks the cancer in place. Patients who might otherwise be facing a really rapidly deteriorating condition suddenly find their tumors completely stabilized, sometimes remaining quiet and totally controlled for years and years. And, this brilliantly illustrates the ultimate philosophy of modern neuroendocrine treatment. One specialist hit the nail right on the head when they said, it turns an active, progressing, growing disease into more of a chronic, stable disease state. Unlike some other cancers where the immediate goal is to use super aggressive, heavy chemotherapy to eradicate every single cell as fast as possible, treating NETs is much more of a long game. The main goal of using targeted therapies like Lutathera is to preserve the patient's quality of life, hit the brakes on the progression, and allow them to live comfortably for years to come. It literally transforms a deadly, terrifying medical mystery into a highly manageable, long-term chronic condition. We've gone all the way from a single, mysteriously mutating cell hiding in the appendix to life-saving, targeted radioactive therapies that seek out and destroy cancer from the inside out. It really is a massive testament to the incredible power of specialized medicine. But it also leaves us with a thrilling question to end on. As radioactive smart bombs successfully turn rare, complex cancers like neuroendocrine tumors into manageable chronic conditions, what other great medical mysteries are on the absolute verge of being solved? The future of personalized, targeted medicine is honestly just beginning, and the possibilities are truly endless. Thank you so much for joining me for this explainer, and keep questioning the science around you.